Today, the last day of this week of largely expert testimony, we have another first for those of us in the inquiry. From abroad, we have Professor Rockstroh joining us from Germany. Professor Rockstroh, can you hear me?
Yes, I can hear you very well.
Thank you. What we're going to do is we're going to start off by swearing in the other experts on the panel, and then Mary, my clerk, will swear you in, take an affirmation from you, and then you'll be asked questions by counsel to the inquiry. Thank you very much for joining us and making the time. We understand you have an hour, and I'm delighted to have been able to take advantage of you for that period of time, at least. So thank you very much in anticipation. May the experts be sworn.
Please state your full name.
Mallika Sekhar.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
David Edgar.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Sara Elizabeth Farrar Marshall.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Richard Gooding.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Kate Ryan.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Oliver Tunstall.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Professor Rockstroh, can you hear and see me?
I can hear you. I can't. Now I see you. Yes, perfect.
Yes, I might stand here. It might be a bit easier. Is that better?
Yeah, I see you very well.
Good. Please state your full name.
Jürgen Rockstroh.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you.
Thank you very much.
So before I ask the experts to introduce themselves and say a little about themselves, I just wanted to say a couple of words about the nature of the evidence that we'll hear this morning and the kind of material that we won't be looking at this morning. So the evidence will follow a very similar format to the evidence that we've heard over the last 4 days, but with a slightly different focus. Whereas the focus of the last 4 days has been looking at impact, in medical and psychosocial terms of the infections, today we're considering some of the underlying disorders or conditions which gave rise to the receipt or administration of treatment, whether by way of blood products or blood for those conditions. And as a result, the report that we have falls essentially into three parts, and our different members of the panel are likely to be dealing with different parts. So the first part looks at bleeding disorders, treated as we know with blood products, particularly factor concentrates. The second part of the report deals with certain inherited disorders of haemoglobin for which regular blood transfusion was a mainstay of treatment. And then the third part of the report looks at primary immunodeficiency disorders for which immunoglobulin replacement therapy was a mainstay of treatment. And so that's why there are a number of different focuses of the evidence today. In common with the approach taken to experts earlier in the week, we will not be asking questions about the correctness or otherwise of treatment decisions that may have been taken in relation to any of those disorders. So whilst the reports do have, and this report does have a section looking at treatment for bleeding disorders, in particular pre-1970 and post-1970, I'm going to be asking very little about that, and I've explained that to colleagues behind. The reason for that's threefold. Firstly, as the panel members have made clear to the inquiry, they were not, in relation to bleeding disorders, clinicians practising in the 1970s and 1980s. So they don't have direct first-hand knowledge to draw on in that respect. Secondly, as a result, when they've sought to give us an overview of the picture in relation to the historic period, they have quite properly drawn on publicly available sources, which has inevitable limitations because the inquiry has available to it far greater amounts of contemporaneous material. And we couldn't possibly ask clinicians to take time out of their full-time clinical practice to look through the thousands and thousands of documents that we have relating to decisions in the 1970s and 1980s. And the third reason is that ultimately, of course, these are the questions of fact that go to the heart of issues at the inquiry that are for you, sir, to determine. That's a long way of explaining that the focus of my questions today, as with the questions earlier this week, will be on what is currently known and understood about the relevant disorders. So after that introduction, can I ask each member of the panel to just introduce themselves and say a couple of sentences about their area of expertise? I'll start with you, please.
So I'm a consultant haematologist at Royal Free Hospital and University College Hospital, and this has been since 2011. I qualified in 1982 and came to England in 87. I had then worked for a bit as a registrar trainee and then became a consultant in 95. My main responsibilities are, at the present time, to look after some patients, some categories of patients with certain types of blood cancers, and to be the lead for the blood transfusion service at the two hospitals I work in.
Professor.
My name is David Edgar. I'm a consultant immunologist. I qualified in medicine in 1995, and I was appointed consultant in Belfast in 1985, and I was appointed consultant in Belfast in 1996. Over the last year, I've been working in St James's Hospital in Dublin, and my main interest relevant to this inquiry is looking after patients with primary immunodeficiencies who would receive immunoglobulin replacement, but I also run a laboratory service and also an allergy service.
Morning, my name is Sara Marshall and I'm a consultant clinical immunologist, and for the last 35 years I've been involved in the care of patients with immune problems, both immune deficiencies and autoimmune diseases. I've also had a research career, and I currently work for a research charity called the Wellcome Trust, where I am head of clinical research.
My name is Richard Gooding. I'm a consultant haematologist working in Leicester. I qualified in 2003 and became a consultant in 2012. I'm currently the Haemophilia Centre Director at the Comprehensive Care Centre in Leicester, and my areas of special interest are haemophilia, and I manage both adult and paediatric patients with bleeding disorders. and I also manage patients with thrombotic disorders and manage anticoagulation.
Good morning. My name's Kate Ryan. I'm presently a consultant haematologist in Manchester. I qualified in 1981 and trained in London before becoming a consultant in West London in 1994, moved to Manchester in 2011. I have been looking, my specialist interest is inherited hemoglobinopathies, so sickle cell, thalassemia, and other rare inherited anemias. And I have about 30 years' experience of managing these conditions.
My name's Oliver Tunstall. I'm a consultant paediatric haematologist in Bristol Royal Hospital for Children. I qualified in '96 and have been a consultant since 2010. I run the paediatric haemophilia service and the Southwest Paediatric Haemophilia Network, as well as managing children's bleeding disorders. I also manage other blood disorders in children.
And Professor Rockstroh.
Yes, so I was qualified in 1989 and I started working at the Department of Medicine, University Hospital in Bonn, where I did my internal medicine and infectious disease training. I became a consultant for infectious disease in 1998. And the story is that in Bonn we have the very large cohort of hemophiliacs, 420, so that's the largest existing cohort with HIV infection. Was treated in our HIV clinic, and that's where I spent my clinical work, did my clinical work, and also my research, which has been mostly around HIV and hepatitis co-infection in the last 30 years.
Thank you. Professor Rockstroh, as we only have you for a limited period of time, I'm going to start with questions that I think you're probably best able to help us with, which is looking at the implications of HIV and hepatitis co-infection, specifically for those who have a bleeding disorder. Can I ask you first to concentrate on the position of individuals with a bleeding disorder who are infected with HIV? That's my first set of questions. Can I just ask, first of all, are there any studies or research that you're aware of that focus on HIV in what I might call the wider infected blood community? So looking at those who were infected as a result of treatment for bleeding disorder, but also partners who may have become infected and the broader family position. Do you know of any research or studies in that field?
Yeah, so we obviously analyze our own cohort of infected hemophiliacs, so that there's a limitation that it's mostly hemophiliacs. We have some von Willebrandts, but these were numerically much lower. And we also looked at their partners. We had 10% of the female partners got HIV infected. We have a paper published on that. The overall course of HIV in hemophiliacs or other bleeding disorders is not too much different from other patients who acquire HIV. So in my first analysis, because that's what I did my research on, it looked as if the outcome was maybe a little bit more favorable in hemophiliacs, mostly based on the fact that they do not develop Kaposi sarcoma, which was very prominent in gay men, and also if it became pulmonary or manifestations in the colon and so forth, had bleeding events, and chemotherapy was difficult. With advanced immunodeficiency, KS took very bad terms, and that may have contributed to some of those people dying from KS. In the setting of IV drug users, we obviously have a high rate of suicide and overdosing, so that had a little impact on their overall survival. But in general terms speaking, the over average time in untreated HIV was around 10 years, and after AIDS-defining event was 2 years survival. And that obviously all changed with the advent of antiviral therapy, but really the overall figures are very comparable to other groups.
I think you've identified in the reports, because you contributed also to the hepatitis and HIV reports, you've identified, I think, one particular impact that HIV may have on a person with a bleeding disorder, which is that it can cause thrombocytopenia, which may increase the bleeding risks. Is that right?
Yeah, so in consideration of the increased bleeding risk overall in the setting of a bleeding disorder, I listed that because it's the only HIV-associated manifestation which could have an impact. I think it's fair to say, though, that mostly patients with low clot, which is a common finding in untreated HIV infection, didn't really lead to a lot of bleeding episodes. But I have to say that in the context of hepatitis C, you can also develop thrombopenia, which is a sign of advanced liver fibrosis and usually occurs in the setting of cirrhosis. So if you have HIV and hepatitis C, and you had sort of HIV-associated thrombopenia, which was enhanced in the setting of cirrhosis, that could have had actually an impact and was more likely to lead to bleeding events. And obviously, that plays also a role in the setting of advanced liver disease when you have varices and can die from variceal bleeding.
And I'll come on to hepatitis C again in a moment, but just sticking with HIV and bleeding disorders, treatment for HIV, have there been any particular adverse impacts from HIV treatment? We obviously know there are lots of adverse impacts from the treatment itself, but specifically on a bleeding disorder. You've identified in the reports some reports of increased bleeding episodes under commonly used first-generation protease inhibitors, I think.
Yeah, so there was in particular a German group in Münster which reported an increased bleeding frequency in hemophiliacs receiving first-generation protease inhibitors for HIV therapy. This was not really reproduced in our cohort, but I have to say that our hemophilia treaters had a different substitution policy, which was always leaning towards the preventive substitution, so daily administration of factor units to prevent any kind of bleeding episode, which may have covered this increased risk. So if you are in a center with a strategy which was less frequent in administration of blood factors, then that might have been true and would have been covered in our cohort. So there are reports in literature which do suggest that there may have been a higher bleeding episode risk under HIV protease inhibitors.
And then looking at it the other way round, you've touched on this already, but the impact of bleeding disorder on the progression or severity of HIV or treatment for HIV, you've identified in your report, obviously, what you describe as profound and multifactorial impacts of HIV on this cohort. But from a clinical perspective, and leaving aside Kaposi's sarcoma, which you've addressed separately, as I understand your report, the clinical course of HIV or AIDS is not materially affected usually by the cause of transmission, the transmission risk group that the individual fell within.
Correct. I mean, obviously, it is all the differences you see between the different key populations really comes from lifestyle, right? So in the IV drug user, you have all these additional aspects. You consider the hemophiliacs were, more likely to be adherent to therapy, come for visits, and so forth. So that's maybe why they may have just a little bit of a better outcome compared to IV drug users. But otherwise, and if you take the case aside, I think there really is no difference. It was the same natural course.
You've identified in your report that one factor that seems to make a significant influence on survival rates was age at time of HIV seroconversion. Is that right? And is it understood why?
Well, I think we have to appreciate that with age, you also have changes in your immune system. So in general, you would think that someone who's aging, that probably a loss of CD4 count will be more meaningful because per se, in the setting of age-associated immune deficiency, you will be more likely to be prone for infections. So bacterial infections may be more prominent and so forth. So I would say, yes, age is a big player in that setting.
And then were there any treatments for AIDS-defining conditions that wouldn't have been available to those with bleeding disorders?
Let me think. So the majority of patients I saw first developed usually fungal disease. So they had oral thrush and then esophageal candidiasis, and that could be treated equally well. I think there's always the limitation that patients with hemophilia or other bleeding disorders had concomitant hepatitis C, so the risk of hepatotoxicity is clearly enhanced in this patient population. So that would be one limitation. And obviously in the setting of liver cirrhosis, if you treat tuberculosis or other things where you use a lot of hepatotoxic drugs, that could have had an impact on the dosage or the duration of your therapies because of side effects. But in general, you can use the same drugs.
And then in relation to hepatitis C, can I ask similar questions? What impact does hepatitis C have on a person with a bleeding disorder or for treatment for their bleeding disorder?
Yeah, so I think it doesn't really have an impact on the treatment of the bleeding disorder, but obviously the liver disease can eventually move on to liver fibrosis, cirrhosis, and bleeding complications like rectal bleeding, and then obviously that can be enhanced in the setting of a bleeding disorder.
And treatment for hepatitis C, were there any particular issues in relation to hepatitis C treatment? And we've heard a lot of evidence about the side effects and adverse events associated with the interferon era treatments. But were there specific problems for those with the bleeding disorder, either in terms of impact, different side effects, or resistance to treatment?
I think that in general, because most of the hemophiliacs had a genotype 1A infection, that seemed to respond less favorably than some of the other genotype infections. So I think the prevalence of more advanced liver disease was higher, the unfavorable genotype. And so overall, if you look at the treatment outcome of interferon-based regimens, and hemophiliacs always tended to be somewhat lower. Now, fortunately, that has all disappeared in the DA era where everyone is responding so well. But clearly, treatment in hemophiliacs in the early days with just interferon ribavirin was relatively challenging with regard to the outcome, which always tend to be a little bit poorer. And so a lot of hemophiliacs were not willing to undergo this intervention because of the low promise of cure following this intervention.
And are there any studies or research that you can direct us to looking at life expectancy for those with bleeding disorders infected with HIV, hepatitis C, or both? Not necessarily asking for a list now, but if you can tell us what you know, and we may ask you to supply more details in writing.
Yeah. So obviously, the life expectancy is affected by all of these concomitant diseases. So even in the setting of having just hepatitis C, you still have a higher risk of developing liver cirrhosis and hepatocellular carcinoma and dying from these complications. And so that's still much higher. So that impacts obviously your overall survival. In the setting of HIV, you obviously have diminished survival with regard to the old days where we didn't have any antiviral regimens. And then I think what is particularly important in the context of HIV and hepatitis co-infection, because obviously most of the patients had hepatitis C. So if you had HIV, your likelihood of having hepatitis C at least was very, very high. Then you had an even much more increased risk of dying from liver disease. And that was particularly true if you belong to those people who started to develop more progredient immune deficiency. So the more CD4 count you lost, the higher your risk of dying from liver disease. And that has been also the reason why there were particularly guidance in the European treatment guidelines for people with co-infection to start HIV therapy earlier to prevent the CD4 count loss, which then triggered a faster fibrosis progression in these patients. Then the patients who have beyond HIV and hepatitis C, also an additional hepatitis B infection was also associated with a more unfavorable outcome. And there were patients with hepatitis B, C, and D. And just to underline the significance of these viral interactions, of all the hemophiliacs we had, every patient with hepatitis B, C, and D and HIV died prior to the advent of highly successful antiviral therapy, because the outcome of liver disease was the worst, and the patients all died prior to the onset of having these regimens available. So that's really the worst outcome altogether. But clearly, liver disease has been a main issue in this patient population for all the different respective viral infections.
And there is faster liver disease progression, faster progression to fibrosis and beyond in co-infected patients.
Yeah, and so we were one of the first groups to examine that, because we saw patients turn yellow basically really in clinic. And first I thought it might be related to the antiretroviral drugs we were using, different elimination and potentially accumulation of toxicities in patients who were cirrhotic, but it then really turned out that in the setting of low CD4 counts, patients had an accelerated fibrosis progression. I compared stable CD4 counts, stable-wise hemophiliacs, with those who had progredient immune deficiency, and really saw that that was the group where we saw a lot of people dying from liver disease. So we could clearly establish that. I think one of the interesting questions was, is this reversible if you start giving HIV therapy and have an increase in CD4 count? And there are big cohorts from the United States looking at that and showing that even the setting of giving antiviral therapy, you probably still have a somewhat faster fibrosis progression. So unfortunately, HIV does take an impact on the negative side there.
And then, can I ask about a different way in which there may have been a burden or impact for those with bleeding disorders infected with HIV and or hepatitis C? And that's the burden of treatment. These are individuals who will already be having to, particularly if they have a severe bleeding disorder, have a substantial amount of treatment. Add to that the burden of treatment for HIV, and we heard a lot of evidence yesterday about how problematic the HIV treatments were in the early decade. And then add to that the burden of the interferon era treatment. Is that something that you observed in your clinical practice?
Yeah, absolutely. I think there are even some things to add, because so first of all, not only do you have all these issues with the various drug treatments for different diseases, but in the setting of co-infection, we also recommended longer interferon durations, which were very burdensome for the patients to tolerate. And unfortunately, because the infections were acquired so early, which means that a lot of the patients had to start early HIV drugs with a lot of side effects. So if you look at patients today, when they start antiviral therapy, it's really a little bit different, because the amount of patients discontinuing therapy because of side effects is so much lower than what we had in the old days. And a lot of the drugs we were giving for treatment of HIV, those have interfered with the hepatitis drugs, right? So ribavirin was not combinable with all drugs. So there was more anemia if you had AZT on board, and they needed more transfusion. So it was really quite an augmented and enhanced toxicity profile in this mix of old HIV drugs in combination with interferon ribavirin. But even when DAAs became available initially, because of the fact that they had acquired a lot of resistance under failing HIV regimens, there was a need for trying to find how can we find DAAs which are combinable, because there were a lot of drug-drug interactions between HIV drugs and hepatitis C drugs. That sort of has all disappeared in more recent years with the broader access of different regimens we now have for treatment. But in the early days, treatment in this particular group was actually quite challenging because of the high amount of drug interaction, the presence of HIV drug resistance from earlier non-suppressive regimens, which were used obviously in a patient population with a very long duration of HIV infection.
And presumably one might add to that somewhat complex picture, not just the treatment for the bleeding disorder, the hepatitis, the HIV, but the potential regimes of treatment that an individual might undergo to deal with the side effects of treatment, the AIDS-defining conditions that might have been developed, the psychological, mental effects of everything that individuals were undergoing. So there may have been a multiplicity of treatments. Do you know?
Absolutely.
Do you know whether there were specific contraindications for different treatments, or particular problems experienced by this cohort in terms of receiving treatment for the wide range of side effects and other consequences they might have been experiencing? It's a long way of putting a question.
Well, there were some contraindications coming from drug-drug interactions. No? So in the end, you had to look at every patient and see what was, because obviously you don't want to let HIV replicate. So HIV control is your first absolute must. And then you have to see with which drugs is that possible, and does that allow co-administration with some of the other drugs, or is this going to lead to enhanced toxicity, and do you have to, I don't know, give EPO or transfusions to compensate certain enhanced toxicities? So there were clearly special aspects around drug-drug combinations. I wouldn't say that there was any real contraindication in general, other than that, obviously in the setting of cirrhosis, you also have contraindications for, so you can't treat someone with decompensated cirrhosis, for example, with interferon, and you can't treat someone with decompensated cirrhosis with most of the DAs because they're not licensed for more advanced child stages. So there are some limitations reflecting on liver disease stage and drug interactions.
Professor Rockstroh, thank you. I'm going to turn to some more general questions about bleeding disorders, which will be directed at the panel who are sitting here.
Sure.
But please do, in the time that you have with us, I think we've got you for another 25 minutes or so on the line before you have your other clinical commitments. Please do join in, contribute, add to anything that's being said by your colleagues.
Could I just make a couple of comments?
Yes, of course.
So one is about platelets. So thrombocytopenia was a problem and is a problem in this group of patients. One of the things we learned through the early 90s was treating the HIV can improve the thrombocytopenia. And so we became more and more confident about treating thrombocytopenia in the HIV patient cohort. The second thing is that in the last 10 years or so, treating thrombocytopenia has become more easy, and this is especially with relevance to the hepatitis C group of patients. And there are new drugs that were introduced and clinical trials done. So again, treating thrombocytopenia has become easier. It still is a problem, but it's now possible to treat them such that it doesn't interfere with other things.
Thank you.
The second point is about biopsies in patients with bleeding disorders who might have, say, AIDS-related lymph node enlargements. It was not easy to do that because they were having a bleeding problem, but it was also very difficult in the initial stages to have proper, correct types of diagnosis because people didn't know, histopathologists didn't know how to interpret what they were seeing under the microscope. So it took a while before they could distinguish it from cancers and just HIV-related changes.
Thank you. So I'm going to turn to the first part of the report and ask questions about what's currently known about some of the key bleeding disorders and what the current treatment regimes are for them. I'm going to start with haemophilia A and ask a member of the panel, perhaps Dr. Gooding or Dr. Tunstall, to tell us, first of all, what is haemophilia A? And I'm conscious that many people here will have a much greater knowledge than any of us about that, but part of our purpose in asking these questions is wider public education.
So haemophilia A is a bleeding disorder, obviously characterised by reduction of one of the clotting factors, factor 8. It ranges in severity from a very mild condition to potentially very severe, and it's characterised by bleeding into typically muscles and joints. The bleeding severity tends to correlate quite well with the levels of factor 8 that are detectable in the bloodstream. So a very significant reduction, so typically between 1% and 3%, is characterised by a severe bleeding tendency. And we can see essentially what we call spontaneous bleeding, but it's essentially driven by normal activities. It's not truly spontaneous. We don't see it in very young infants until they start walking usually. So it's that sort of level of very mild trauma within, say, joints and muscles that can lead to this sort of what we call spontaneous bleeding. And then that can lead to, well, obviously the acute problems, so that sort of pain, discomfort, reduced mobility and that sort of thing, and then much longer term problems with joint damage.
And haemophilia A mostly affects males. I'm going to come on to some questions specifically about how it affects females later. Do you know approximately how many people with haemophilia A there are currently in the United Kingdom?
I haven't got that statistic with me. It's part of the UKCDO statistics, but I'm afraid I don't have that
Don't worry,
off the top of my head.
Extract that from the national reports.
Yeah, I'll put an exact number. It's in the thousands.
Yeah.
And then in terms of what causes haemophilia A, or how people may come to have haemophilia A, it's an inherited condition. but not for everybody. So there are some for whom it occurs spontaneously through genetic mutation with no family history. Is that right?
Yeah, so there's, I suppose if you're looking at it in terms of inherited and not inherited, there's the more common inherited form in which there's a problem with the X chromosome, and that can either be inherited, as in predictably through a family, so there's a known diagnosis, but it can occur with a spontaneous mutation as well, and that's about 50% of cases are seen in that way. There's also, so that's all inherited. There is an acquired form of haemophilia as well, which is an autoimmune disorder, which is typically seen in older adults, and that's an autoimmune condition, so that's very different. So in that individual, they will have had normal levels of factor VIII, and then an antibody will have been produced, which will reduce the effectiveness or the levels of factor VIII. So those are the sort of differences there.
Sorry, can I just...
Yes.
We do use the term inherited in a slightly confusing way, I think, in that inherited is often used as synonymous with congenital, with birth, or genetic in that sense. So even cases where there haven't been recognised cases of haemophilia in the family, we would still consider it an inherited bleeding disorder.
Because it's not acquired in the way that's just been described.
As opposed to acquired, yes.
In terms of diagnosis with haemophilia A, as I understand it from the report, there may be what you call targeted testing of a baby because there's a known history of haemophilia A in the family, or there may be children who present with symptoms, bruising, bleeding without a family history. Is that right?
So that's right. So if we're aware of haemophilia in the family, then and we are aware that a pregnant woman is known to carry, have one copy of the affected factor VIII gene, then they will typically should be referred to see a haematologist during the pregnancy, and then plans can be made. And there are various choices about when testing can be done. So there's the option of antenatal testing, antenatal genetic testing of the fetus, or plans can be put in place to test a newborn baby immediately, which is usually done on cord blood. Then there are the cases that come to light for other reasons. Typically for severe haemophilia, that's very early on in life that they're noticed to have bruising or bleeding within the first year or two of life, and then typical investigations, the basic screening, clotting screens are usually grossly abnormal, and hopefully somebody puts two and two together and the more specialised testing is done and they're referred to a specialist team.
And in terms of that specialised testing, you've identified two sets of tests, something called APTT and then factor assays. And I wondered if you could just briefly explain what those are for us.
So there are tests that are done very commonly in a hospital. So there's something called a coagulation screen or a clotting screen, which consists of tests where basically blood is spun into its cellular component in the plasma, and the plasma, which is the liquid component of blood, is then tested with activators to see how quickly it forms a blood clot. And you can use different activators, and they give rise to the PT and the APTT. And those timings are to a certain extent predictive of levels of the soluble clotting factors, such as factor VIII. So in haemophilia A, one would expect a very prolonged APTT, certainly in severe haemophilia A, than an extremely prolonged APTT. And then that would lead, hopefully in the clinical context, to more specialised testing of the actual factor VIII activity within the blood.
And then we have, as we've heard, and indeed we've heard from a lot of the evidence we've heard from individuals, the classification of haemophilia A into severe, moderate and mild. I think you've touched on the levels that would identify severe haemophilia. Could you just talk us through the different levels of factor VIII that would lead to someone being classed as mild, moderate and severe?
So typically the classification would be that severe patients would have less than 1% factor VIII levels, Moderate patients would be between 1 and 5, and then mild would be 5 up to perhaps 30, or to the lower limit of normal. So that's the classification. Although there is a, I mean, as with anything in life, it's a description of a more complex sort of system, really. So there are other factors that can lead to bleeding, and so there is some. Whilst there is good correlation, and that's a nice classification, there may be people who, for one reason or another, may have a more severe phenotype, a more severe sort of expression, even though their levels are slightly higher, or who conversely might seem to be relatively protected for other reasons, even though the levels of factor VIII are low. So it's not an absolute, but it's probably the best description that we've got, really.
And I said I wasn't going to ask you anything historical, so please tell me if you can't answer this. But are those levels ones that have been, as far as you know, fixed in clinical practice for a significant period of time, or have there been a number of changes over the years?
I think they're pretty fixed, aren't they?
I believe in the UK we often used less than 2 as severe rather than less than 1. And then there was an attempt to standardise things internationally, which used less than 1. There's actually a sort of growing movement as the evolution. There are practical implications for how one recommends treatment in haemophilia depending on those levels and depending on that classification. And so there is a certain amount of questioning whether we should consider severe as in particularly those children who are likely to develop spontaneous bleeds and to develop joint problems and should be considered for regular preventative treatment as severe, maybe less than 3. But for now, formally, we use less than 1, 1 to 5, and greater than 5.
Before you go on, the percentage is obviously a percentage of something, and it would imply 100%, so 1% is 1/100th of that. But what is 100%? I understand that's not, as it were, the most you can get. That's normal, is it?
So 100% is based on if you measure 100 or 1,000 people without haemophilia and you draw factor VIII and you get a nice normal curve, then 100 is based on the average level.
The average or the median?
Well, the average, which is pretty much the median, I think, in these cases. And then normal range is considered approximately 50 to 150. So it's the machines are calibrated to that standardised setting.
Has the arising out of Council's last question to you, has the sense of what 100% is, or the normal 50 to 150% is, has that changed over time, or has that been broadly consistent in terms of international units?
I couldn't say whether it shifted at all. I suspect it shifted a little bit, and there are efforts to standardise these things, so we establish international units. So rather than percent is what we often use, and it's well understood and easy to talk about. We often use, there's an equivalent measure, which is international units per decilitre, which gives the same numbers. And there are efforts internationally to set that standard. I don't know to what extent that shifted, but in some ways the normal levels are less important than the bottom end, because the difference between having levels of 95 or 100 is insignificant, while the difference between having 1 or 2 can be very significant.
It is an important point, though, actually. I think that mentioning percentage, because it does sound confusing, because to have a 50% being normal just sounds strange, but it is... it's just the terminology that's used. So, 100%. We're not aiming, 100% is not hemostatically significant necessarily. If you might be aiming for 50% or 40%, and that may be okay in terms of, having a response to treatment, for example. And you might consider the normal range to be down to around 50%, like you said. So that it sounds like it doesn't make sense. So it is I think that there is a shift to move more towards units as an absolute term, and I think that it sort of depends on the laboratory standards that you're using as to which terminology you use to describe the result.
Can I add something? Just to say that over many years now, all laboratories that test any of these biological values, but particularly laboratories take part in national quality assurance schemes. So it means that a level, in theory, tested in one lab should be the same tested wherever that is. So it should be the same across the country.
Thank you.
Again, you may not be able to answer the next question, which is about numbers again, and it may be that we need to look at material from the National Haemophilia Database for that. But do you have a broad understanding of what the proportions are of those with haemophilia A in the country who would be classified as severe as opposed to those who would be classified as mild or moderate?
Broadly, if you look at the numbers under care, it does vary from centre to centre and may vary on diagnosis rates and referral rates, but the severes and non-severes tend to be of similar numbers, with moderates as a lower number. But I think it depends on very much on centre to centre.
I'm afraid I've not got the absolute numbers, but
Don't
the
worry.
UK CDO bleeding disorders statistics data is useful for that.
And then I just wanted to ask a little about the bleeds themselves and the potential significance of bleeds. So you've described how someone with haemophilia A can bleed into the closed spaces within the body, muscle joints, but also into the brain or gastrointestinal tract. Can you just tell us a little more about that? Tell us about the process by which blood is toxic to joint surfaces, and tell us what target joint is, a phrase we've come across, I think, quite often in the evidence we've heard, and haemophilic arthropathy.
So, unfortunately, the bleeding into joints is a typical pattern in haemophilia, and there appears to be something about the process of once there's blood in there, iron is a central component of blood, and iron is not reabsorbed very well, and the process of bleeding, and particularly the iron, starts an inflammatory process in the joint in a relatively unpredictable way, but something that is associated with the more bleeding there is in a joint, the more likely that is to happen, although it can happen after one bleed, or it may not happen clinically after 10 or 15. And that can form a vicious cycle in that when you have more inflammation and more damage to the joint lining, that means that the joint is more likely to bleed. It often leads to muscular imbalances around the joint, and therefore you have a situation where once you've bled into a joint, you're more likely to bleed into that joint again, and that causes progressive damage, and that damage can be very severe and very disabling. So the natural history of haemophilia, or particularly severe haemophilia, without treatment is progressive disability. With modern treatment, we hope to stop that process, but results of joints in people with haemophilia, even with modern care, are not perfect by any means, and people with haemophilia end up having joint replacements at very young ages, and other problems with their joints.
And I think you've explained in your report that without treatment, these bleeds can be painful and debilitating and sometimes fatal. And I just wanted to, again, explore that a little more, because what you've also said in your report is that typically those with severe haemophilia may suffer severe disability and early death. And I wondered what that suggestion might be based on in terms of any research or studies, because presumably for a number of decades, people with severe haemophilia have been treated in a range of different ways. So what is the cohort of those who are without treatment that you're able to base those conclusions on?
I suppose it's the historical perspective, really. So we know, through the last sort of 100 years or so, that life expectancy's improved. with modern treatment. So if you're looking at just the absolute sort of life expectancy side of things, it's that sort of data really. A modern study would be unethical in terms of treatments. The more recent studies, I suppose, have been based on prophylaxis, so providing a measure of a level of factor VIII, ideally all the time to a certain degree, which has been shown in a number of studies over the years to improve overall joint health, and that's true for starting this prophylaxis, so regular treatment at a young age to protect joints. So that's been shown to be beneficial in children against no treatment or on-demand treatment, so waiting for a bleed to happen. And it's been shown in adults as well. So there's good high-level study evidence to support that. But that's looking at joint health and numbers of bleeds. I suppose there's sort of, in some ways, it's difficult to measure nowadays because the care's got better and better, but it was looking at fairly crude measures like the number of bleeds that happen over a year, sort of thing.
And the other comparative group is that haemophilia care remains very expensive. And it's available in high-income countries, but it's very uneven throughout the world, and in many low-income countries, then children get very inadequate care for haemophilia, if any care at all.
In terms of the kinds of bleeds that might, without any treatment at all, and happily for the United Kingdom that is a historic position, but without any treatment at all, what kind of bleeds could have been fatal? I can understand that the kind of joint bleeds you're describing causing pain, potentially disability. In terms of bleeds that might be fatal, are we really talking about bleeds into the brain?
Bleeds into the brain, certainly. Bleeds into the gastrointestinal tract, anywhere down there. So tongue bleeds could be fatal. Bleeding from the gut, anywhere down the gut, could be fatal. Operative bleeding could be fatal.
Presumably, the effects of progressive immobility also has an effect in itself in shortening life.
One would imagine, in general, yes.
I'll just add, in some of the reports from the 1970s, there are lists provided about the sites of bleeding, and they usually split into brain bleeding and other types of bleeding. The other types include this, but also soft tissue, so bleeding into muscles is a big problem.
Is there any data that you're aware of that would assist in understanding the frequency of those types of bleeds that you've just been describing, so the ones that can have a fatal outcome in those with haemophilia A who receive no treatment? Maybe the answer is there isn't any.
I think it's very difficult to have good cross-sectional data without any treatment nowadays, to be able to understand numbers. Yeah.
And see, what we've been focusing upon there is something which would be predominantly a concern for those with severe haemophilia A rather than mild or moderate. Is that fair?
Mainly, yeah. I mean, obviously it is possible to, like you said, perioperative bleeding can happen, with mild and moderate haemophilia. Bleeding into the brain can happen as well. So there's various, and into the GI tract. So it's not entirely unique, but it's a higher risk in this.
It's rates of bleeding that really vary between severities, and it would be unusual to see, as Richard described, spontaneous bleeding in those with mild haemophilia, as it's termed, but bleeding still occurs, and bleeding can be very significant, very serious.
And do factor levels or the severity of a bleeding disorder fluctuate naturally over a person's lifetime?
In general, no.
For severe, at least.
Yes.
Yeah. But for more mild disease, you see sort of fluctuations. So typically, factor levels will be higher for the first 6 months of life, and then bottom out, and then maybe gradually rise So it does depend a little bit on your baseline starting point. So if there's no factor VIII at all, then it's not likely to change. But if you have a degree of, a sort of milder sort of level of reduction, then it can change. And we see that in female carriers as well. So if a woman's a carrier of haemophilia and has a slightly low factor VIII level, which we do see, then typically those sorts of levels will fluctuate. A good example would be in pregnancy, where the levels may start at 25, 30, something like that, and then normalise through the pregnancy and then drop back down again. So there is some variability, and that, I guess we'll touch on that later, but that tends to mirror the sorts of time periods where von Willebrand's factor levels can fluctuate as well.
Before we talk about the different treatments that are currently available for haemophilia A, can I just ask you some questions about how one might manage the condition without treatment? Now, I think both of you, your professional careers in relation to haemophilia have been in the recombinant era, so these questions may not have much resonance for you, but advice about managing activity, advice about bed rest, advice about not undertaking certain activities, that can in principle at least form part of haemophilia care. Does it form much of a part of modern haemophilia care?
Probably less so, but
I mean, so the philosophy in general, I mean, certainly speaking about managing children with haemophilia these days, is for them to lead as normal a life as is possible. And we try to facilitate them living a normal life. We do put certain limitations, and those limitations usually are don't take up rugby, and don't do contact martial arts or boxing. But it tends to be as limited as that. There can be a case if there are certain activities that are particularly risky, then we would have discussions about them. So, we have patients doing downhill mountain biking and just how you manage the risk associated with that. And we might have boys who are playing a high level of football who are seeing problems with their ankles, and you have to have realistic conversations. But it's generally a discussion about how best, how we balance risks and limit them as little as possible. We do use secondary rest in management after a bleed at times. Not usually bed rest as such, but a period of relative rest or non-weight bearing to help manage a bleed.
And then before we look at any particular treatments, which we can do after the break, just talking about the philosophy of treatment, and again, these are questions about what you would currently do. The primary aim of treatment is to increase the levels of factor VIII. That's why you would give treatment.
Primary aim of treatment is to allow people with haemophilia to have normal lives. To do that, we want to prevent bleeds. To do that, we want to increase the level of factor VIII, and or if they have a bleed, then the primary way of managing that bleed is to increase the amount of factor VIII.
And then just one other thing, just on that point, well, that has been up till very recently the aim. There are some new treatments which technically don't affect factor VIII, but still have the same effect. So it is about reducing, normal quality of life and reducing bleeding with whatever medicines we've currently got. But there's some newer treatments which have obviously come out which are not quite doing that.
And you've alluded to this already, but there is two broad concepts of a treatment programme: preventative prophylactic treatment, which, as you've described in your report, might be long-term, particularly for someone who is classed as a severe haemophiliac, or might be short-term because surgery is planned, and then on-demand or reactive treatment, which responds to there being a bleed. Is that broadly accurate?
Yes.
So I note the time.
Yes, I just wonder if Professor Rockstroh would like to add anything to what has just been said over the last 20 minutes or so.
Yes, Professor Rockstroh, before we rise, is there anything further that you would like to add at this stage?
No, I think all the aspects were covered and it sort of reflects our own experience as well. So I'm all fine with which has been said and expressed.
Thank you.
Well, I think we have to say goodbye to you at this stage because your time is limited, Professor.
Yes, thank you very much.
Well, thank you. Thank you enormously. It's been a privilege for us to have had you online and in a busy schedule. So thank you very much indeed. We'll take a break ourselves now for half an hour to allow those who are listening to have coffee or whatever. And we'll return without you, I'm afraid. But thank you very much.
All right, thank you very much.
That's
you set out in your report the current standard of care for a child diagnosed, first of all, with severe haemophilia. Can you just tell us briefly what that is, what treatment you would typically expect a severe haemophiliac child to receive?
So we're actually in a little bit of flux at the moment, but the standard of care would be for a child with severe haemophilia would be to start preventative treatment with recombinant factor VIII at or before their first joint bleed. And so typically we look at times when the child is going to become more mobile and more at risk of bleeding into a joint. So that can be around the age of 1 year. And in general, we try and prevent them having joint bleeds. As we talked before, that any joint bleeds can lead to damage. Our feeling, certainly as an institution, is the earlier we start, the better. But there's an element of compromise. Often we need to insert a central venous catheter to give regular treatment, getting access to veins. Factor VIII can only be given into veins, and getting access to veins in small babies is difficult. And so the kind of compromise measure is to start around a year, sometimes 10 months, sometimes a bit after a year. And we start regular what we call prophylaxis, preventative treatment with recombinant factor VIII, trying to maintain a baseline level of factor VIII so that they have protection from bleeding. And with that, we would aim that they don't suffer any bleeds at all. And certainly on any given year, we would hope that most of our children wouldn't have any joint bleeds, certainly, or any significant bleeds. So they may require extra treatment for a bang on the head or something like that.
And then, again, typically, what would be the approach to a child who has either moderate or mild haemophilia?
So mild haemophilia is easy. We would not normally recommend what we call primary prophylaxis, that it would be unusual to require prophylaxis for anyone with mild haemophilia. And normally the approach is information and guidance and then treating problems as they come around. So if there is bleeding, then we treat that, as we say, on an on-demand basis. For moderate, then it's more controversial, let's say. There's more things to consider. There's a certain amount of evidence that in the last 20 years or so, as we've been better at starting primary prophylaxis in patients with severe haemophilia, that actually the burden of disease has been pushed over to those with moderate haemophilia. So they have more problems with their joints than our children who started on early prophylaxis. And so for that reason, for a child with levels of 1 or 2% as opposed to less than 1, we would be discussing giving primary prophylaxis. I think anything above 3, we would normally be taking a watch and wait process and only treating on demand. But we may consider, if a child's having joint bleeds or having problems there, then we might do what we call secondary prophylaxis, where we start prophylaxis in response to a bleeding pattern rather than in anticipation of a bleeding pattern.
And it's just important to note that it's what the sort of rationale behind that is a risk assessment, obviously, between the numbers of bleeds, the severity of bleeds, and then the risks of treatment. So you could say, why don't we just treat everybody who has a low factor VIII up to normal, and that, then they're normal, normal levels, and reduce bleeding risks altogether. But obviously, the worry is the development of inhibitors, these inhibitory antibodies, which render subsequent factor VIII therapy very difficult or ineffective, and so that we think that carries a bigger risk. So the severes, obviously, with severe disease, you've got a higher risk of permanent joint damage and more bleeding. And then as you move away from that, it's felt to be safer not to give regular prophylaxis, and as Oliver's described, that's that's what we would do.
And you've alluded to inhibitors. Could you just tell us briefly what inhibitors are, how they arise, and if you know at what age they might typically emerge?
So inhibitors are basically antibodies against the infused factor VIII. So for many children, particularly with severe haemophilia, they don't produce factor VIII or don't produce normal factor VIII, and the body's immune system doesn't recognise it as part of the body and will produce an immune reaction to start producing antibodies against that. We know very well from international and national registries that happens in somewhere between 1 in 4 and 1 in 3 children. They will start producing antibodies that stop the factor VIII from working. That's what we call an inhibitor. Sometimes that's at a low level and will quickly go away if we continue giving factor VIII. And sometimes those antibodies are at a high level and can be very problematic for years and sometimes indefinitely. They typically occur within the first 20 exposures to factor VIII, so they typically occur fairly early on. So they're typically occurring in babies or young children. They are a significant problem in haemophilia care. We know that if we can't get rid of the factor VIII inhibitor, then managing haemophilia is much more complicated, as we can't give factor VIII. We have to give something else which is going to help the body to clot.
And do inhibitors typically emerge in childhood, or can it be adulthood? Is there any particular pattern?
So they're generally more common in severe haemophilia. We generally expose children with severe haemophilia to factor VIII in early childhood because we're giving regular preventative treatment, and they generally occur in the first 20 exposures. So they almost, in the context of severe haemophilia, they almost always occur in childhood. They can occur in non-severe haemophilia, and that risk is more spread out and can occur at other ages. And whilst the majority of inhibitors occur in childhood, they can occur at later age.
And what you've described in the report is an initial management process that you've termed tolerization.
Yes.
How does that work?
So immune tolerance, we know from experience that if we can keep on exposing the immune system to the protein, to the factor VIII, that often it stops producing an antibody response to it. And this is done by essentially continuing to give factor VIII, and that can be done either what we would call low dose tolerance, which is at similar doses to standard prophylaxis, given every couple of days, or it can be given in high dose daily, sometimes even twice a day, of much higher doses of factor VIII. And with that, about 3/4, 4 out of 5 cases, we can get the inhibitor to go away to the extent that factor VIII is an effective treatment once more.
And for those who don't successfully respond to that management process, treatment options traditionally have been, I think, FEIBA, F-E-I-B-A, and Novo-7.
Yeah. So FEIBA is something we call activated prothrombin complex. FEIBA is its brand that it's sold under. It's a plasma-derived product which basically contains a lot of activated clotting factors. Doesn't contain factor VIII, but it kind of bypasses and helps the blood to clot in the absence of factor VIII. Novo-7 is a recombinant, so it's made in the lab, not taken from blood donations. It's an activated factor VII. Both of them can be effective at treating bleeds, are effective, not as effective as factor VIII. People who have long-standing inhibitors have had far more problems as far as problematic joint bleeding, etc., than those who don't have inhibitors.
And then there's a current treatment now, and I've been challenged to get the pronunciation of this right, emicizumab.
That's pretty good, yeah. So emicizumab or Hemlibra has been a revolution in managing patients with chronic inhibitors over the last few years, and is now coming into care for patients who don't have inhibitors. It's essentially, it's an engineered antibody itself that it isn't factor VIII, but it does the job of factor VIII. And it has the other great advantage that you can give it by a subcutaneous injection, so an injection under the skin, rather than into a vein, so you don't need to have access to a vein, and you only have to give it once a week or once every 2 weeks. And it gives very effective protective treatment in patients with haemophilia, whether or not they have an inhibitor. So it works equally well in those who have anti-factor VIII inhibitors.
And then can I then ask you to talk us through the current treatments for haemophilia A, just starting with recombinant factor VIII, which is, I think, the mainstay of treatment now for haemophilia A. Can you just tell us what recombinant factor VIII is, what it's made of? Or rather, what it's not made of.
So recombinant factor VIII is made in a laboratory. Essentially, it's made by cell lines. So these are cells taken, mammalian cells, not human cells, and they're treated so that they and genetically engineered. So the main thing they do is produce a lot of protein, and specifically factor VIII. So they produce factor VIII to a certain at large volumes, and then that's isolated from, extracted from that process and purified, and then put in vials and dried in concentrate and sent around.
And the central idea behind recombinant factor VIII, it's not made from human plasma.
It's not made from human plasma.
You've said some products use human albumin in the extraction process. What is that?
So albumin is a major constituent of it's a protein in the blood, in the blood plasma. For extraction purposes, I think a lot of the recombinant products would need to use some human proteins just to stabilize and extract the factor VIII from the cell line. There are some newer products which don't use human albumin, whilst clearly it's not being, the factor VIII itself is not being extracted from plasma, and therefore we feel that there should be a dramatically increased risk of viral transmission. We still think that the risk of viral transmission with recombinant factor VIII should be vanishingly small, but because there are some human proteins involved in the manufacture in some cases, then saying it's completely zero is beyond us.
And what considerations would you have regard to in deciding how much treatment is required to be effective for an individual? What do you look at about the individual in assessing the treatment you give?
So haemophilia care is quite standardised in the UK particularly. We have certain guidance. We plan treatment as a national body through the UK HCDO, and look at guidelines which is written by the UK HCDO. So within that there are certain parameters on starting treatment. So it lays out in the UK HCDO prophylaxis guidelines, it lays out what would be a reasonable starting dose. That dose would then be adjusted according to different parameters, basically to the response to treatment. And the response to treatment would be based on bleeding levels, also baseline factor VIII, measuring the levels and seeing if we're getting the expected target levels of factor VIII. We may adjust it. We're constantly looking at, for example, in children, which is my area, that we'll be looking at their joints, looking at their activity, looking at any problems they may have, and looking for any signs that the treatment is inadequate or not working perfectly for them, and adjusting on the basis of that.
By reasonable starting dose, presumably you don't give the same reasonable starting dose to a small young child as you would to a large, big adult.
So but on a per kilo basis.
So it's per kilo?
Yeah. It's still... Factor VIII, in general, there's a certain element of giving best bang for buck, that it's been an expensive resource. So we're looking at effective dosing, but it's not dosing to try and normalise factor levels. It's dosing to try and achieve factor levels that we know will prevent a certain amount of bleeding. Whether that could still be improved, a lot of us would argue we should be giving more, but we start at a basic dose per kilo. And
then just one extra thing with that is we do some monitoring tests as well. So as you touched on already, but there are some there's some new software that can be used to look at the response to treatment. So you can check a level sort of pre-dose and then after dose, and then maybe a few hours later, and generate what we call a pharmacokinetic profile. So you can actually graphically represent what the factor VIII level is likely to be after a dose, and when it might drop down to, say, 5%, 3%, 1%, and maybe give a dose, the next dose, just ideally, I suppose, around the sort of 3 to 1% mark, so that it's both effective and efficient in the sense.
Well, plainly, the difference between somebody being given factor VIII or making it themselves is that when they make it themselves, it's a constant process, and they constantly maintain whatever the level may be.
Yep.
If you give factor VIII, there'll be, is there a half-life? Is that how it's put?
Yeah.
But what you're saying is that'll differ from person to person.
Yeah. So typically it's much shorter in younger children, and it often gets to around about sort of 12 hours or something like that. But it does depend on the product that's being given, because we may come on this in a minute. But there are some newer extended half-life products, so there's ways of lengthening the half-life, and then we would use that monitoring technique just to see what happens. But there is a big variability between individuals, and so that's where that sort of measuring step comes in.
And I mean, just to say on that if you're producing factor VIII yourself, then, as you say, that you get a constant level more and more. But the curve is a decay curve, so if we give a dose of factor VIII, you get a high level at the point that it's given, and then it decreases quite rapidly down until it's really a very low level towards the end.
You spoke about a baseline level earlier. Is that the lowest to which you want it to drop?
The baseline level that we normally talk about is the baseline of endogenous factor VIII. So that might be effectively 0 for somebody with severe haemophilia A. We talk about trough levels, and trough levels are, again, an area where there are different beliefs, but we know fairly well that if you have a trough level that spends a prolonged period of time below 1% or below 3%, or the longer time that you spend lower down there, then the higher the risk of bleeding. So we want to maintain good trough levels, and that's a fundamental part of the care.
And you've described in terms of frequency of treatment in your statement that when a child with severe haemophilia starts on this prophylaxis programme, it'll be 3 to 4 factor VIII treatments a week on average, subject to extended half-life recombinant, which will make it less frequent.
So normally every other day, every 48 hours is our standard starting regimen.
And is that something which continues at that frequency, potentially lifelong, or or are you able to achieve longer periods between treatments?
In the absence of using extended half-life products, then certainly in paediatric care, would never recommend going beyond 2 days. Sometimes we end up giving daily treatment. If the levels aren't good enough or the control isn't good enough with every other day dosing.
I think that'd be similar for the adult practice as well, really.
And the extended half-life recombinant factor 8 may enable you to extend it to about every 3 days. Is that right?
Yes, on average, they give about a 50% extension of the half-life. So, on average, if you gave a certain dose every 2 days of a standard molecule, you could probably give the same dose and achieve similar levels if you gave it every 3 days. But that's on average, and there's a lot of inter-individual variation.
And then can we look just shortly at some of the other treatments that are still used for haemophilia A? DDAVP,
Yeah.
which we know has been around since the second half of the 1970s. That's a synthetic analogue of a naturally occurring hormone, vasopressin, is that right?
That's right, yeah.
And that will increase the level of factor VIII.
So that tends to increase the levels of factor VIII if there is some factor VIII to increase the levels of. Obviously, for somebody not producing any factor VIII, then desmopressin or DDAVP is not likely to be effective. It causes release of von Willebrand's factor and factor VIII from the endothelium, from the lining of the blood vessels, and you get an increase. It's very variable between individuals, but on average, maybe about 4 times the baseline level. So if somebody had levels of 20, then they might go up to 80, but then we'll reduce from there.
So it's typically used for those with mild haemophilia or von Willebrand's.
Yes.
It's not used for those with severe haemophilia, is that right?
That's right.
What about moderate haemophilia?
In general, not in moderate haemophilia, because normally if we're treating a bleed, then we want to get levels higher than that.
And you've said in your report it's not usually used for prolonged periods of time. Why is that?
There's a blunting of the effect. So when you give the first dose, you get more release and a higher peak, and with subsequent doses you get a diminishing returns. There's also concern about some of the side effects. So this is a physiologically active analogue. One of the things that it does is cause fluid retention and disturbances of electrolytes, so things like the sodium levels in the body, which can cause problems. And if you treat for a prolonged period of time, you're more likely to run into problems too.
But it's an effective treatment for those who don't require long-term prophylactic.
It can be a very effective treatment, yeah. It's situation specific, and I think in the context of life-threatening bleeding, then we'd almost always be using a factor concentrate. But it depends on the situation, and it can be adequate for covering surgery, depending on the patient and the situation.
Would you normally give a test dose before using it?
That's standard practice, yes.
And why is that?
Just because of that variability in response and knowing what levels of response. There's variability in the peak and there's variability in the how long that's sustained for, both of which are important information to know before going into surgery, for example.
Then plasma-derived factor VIII concentrates, you say in your report, rarely used for haemophilia A in the UK. The figures that you've drawn from the National Haemophilia Database annual report show 13.4 million units of plasma-derived factor VIII used for haemophilia A out of a total factor VIII usage of 600 million units. So a small proportion, but nonetheless not a vanishingly small one. When and why would plasma-derived factor VIII concentrates still be used in modern practice?
To be honest, I don't know exactly where those 13 million. I could talk about some of the places that we have used it. There's a certain amount of evidence. We talked about inhibitors before. Certainly internationally, there is some thought that the rates of inhibitor formation are lower with plasma-derived factor VIII. There's a certain amount of evidence, but it's quite controversial. And in the UK, we've generally taken the view that the downsides of plasma-derived factor VIII for primary prophylaxis outweigh the possible upsides. There's also evidence that in the context of immune tolerance for inhibitors, when we keep on giving the factor VIII, sometimes it works beautifully, sometimes it doesn't work. And sometimes when it doesn't work, we use extra measures. And one of those measures has been to try plasma-derived factor VIII. And there's certainly cases where if we give recombinant factor VIII immune tolerance and it doesn't work, if we change to a plasma-derived factor VIII, it has worked. And it may well be, and I don't know in the detail of those, it may well be that there are people who've had inhibitors who've been tolerized with a plasma-derived factor VIII. In that case, we would stay on a plasma-derived factor VIII.
And it's worth noting that for immune tolerance induction, the amount of factor VIII that you give is quite high, so that could explain. I don't know, for definite with these units, but that could explain why there's a relatively high volume there.
And then tranexamic acid.
So should I take this one?
Yeah.
So tranexamic acid is it's a drug which essentially stable or allows stable clots to remain stable without being broken down. So it's a useful therapy for generally mild sort of bleeding problems, particularly in the sort of mucosal kind of tract. So if you're looking at nosebleeds, gum bleeding, that sort of thing, it's something that we use if there's been that kind of bleeding in severe haemophilia, and it's often used in mild haemophilia where, if you're going to have a procedure of some sort like a dental extraction, it can be very useful in that sort of setting. It's also used for heavy menstrual bleeding outside of the setting of bleeding disorders because it helps from that point of view as well. But it is used very widely.
I want to turn to ask you a little about haemophilia B now. Now, haemophilia B is a deficiency of factor IX. Again, could you just outline for us haemophilia B and how it might impact upon an individual and any material differences between haemophilia A and haemophilia B in that respect?
Should I take? Yeah. Yes, I mean severe haemophilia B is actually very similar in a lot of ways to haemophilia A, in that the bleeding manifestations are very similar. The severity levels that have been taken are very similar as well. There's some argument as to whether it may be slightly milder for some people, but essentially the factor VIII and IX in the clotting cascade work at a very similar sort of level, so that you can see why they produce the same sort of disease phenotype. In terms of differences, the inheritance is very similar. The half-life of factor IX is slightly longer, so that's a difference when we come on to sort of therapeutics. But otherwise, they are sort of very, very similar, really, in terms of management as well.
And it's also classified, as I understand it, into severe, moderate and mild. Is it the same levels that are used for the classification as with factor A?
Yeah.
In terms of diagnosis, again, a similar
It's a very
methodology.
similar process, yeah.
So the same blood test will be effectively, we talked about the prolongation of the APTT clotting time. So it's the same, we see the same picture if you're doing the coagulation screen, you get this isolated prolongation of the APTT. And then in the same sort of way, if you're suspecting a bleeding disorder, you'd go on and check that. So I suppose if you were looking at a newly diagnosed child, for example, with bleeding manifestations, the coagulation screen would be done, the APTT would be found to be prolonged. And then typically what would happen from there is that you'd actually do all the clotting factors that are affected. So with an APTT, we would check factor 8, factor 9, factor 11, and factor 12, which is less relevant. And so that, in that respect, we would pick up haemophilia A, haemophilia B, and then take it from there.
Again, it's something that can occur within families, or as with haemophilia A, occur spontaneously.
Yes. Yeah.
Yes.
Yeah.
But basically, the way it's inherited, it's a gene on factor, or on the X chromosome, and it's got the same patterns of inheritance.
And is there any material difference between haemophilia A and haemophilia B in terms of the risks without treatment and the way in which bleeds occur?
Not clear differences, no. No. There's differences in treatment and response to treatment. There's difference in inhibitor rates and the patterns of inhibitors with haemophilia B. But as far as without treatment, then there are no significant differences.
And in terms of treatment, in the case of those who develop inhibitors, FEBA can be contraindicated, is that right?
So it's a relative contraindication. The problem with inhibitors in haemophilia B is they often take an allergic form, and sometimes they can give rise to a very severe allergic reaction, what we call an anaphylaxis. The problem with FEBA is it contains factor 9. So for those who've got an inhibitor, it is still sometimes used in patients with inhibitors against factor 9, but it can cause problems.
The current treatments for haemophilia B, the primary treatment is recombinant factor 9. Is that right?
Yes, so desmopressin doesn't work. And we use tranexamic acid in a similar way. There is some use of plasma-derived factor 9. The recombinant factor 9 is also used. Plasma-derived factor 9 is probably I don't have the statistics to hand, but I would imagine
4.5 million units out of a total usage of 80 million, according to the last National Haemophilia Database report.
Yeah, so a bit higher. There are those who seem to respond better to plasma-derived factor 9 or to have better pharmacokinetics with a plasma-derived factor 9 than with a recombinant factor 9.
And in terms of the recombinant factor 9, the frequency of injections can be less than the frequency of injections with factor 8.
That's right. It naturally has a longer half-life, which means that in general, a standard dosing might be twice a week with a standard molecule. But it's also true the extended half-life molecules are more extended for the factor 9 than they are for factor 8. And in those cases, weekly dosing is typical.
And you've said you can even achieve fortnightly dosing in some cases.
Yeah.
And then haemophilia C, or factor 11 deficiency. Could one of you just outline that for us, please?
Sure. So it's a sort of this is a very different sort of situation, really. So this is factor 11 deficiency. It's typically characterised by more of a very variable disorder, and so we don't see this sort of correlation between factor levels and bleeding phenotype, the sort of type of disorder that you get. So it's not like we can say, these levels are less than 10% or less than 1%. We're going to see joint bleeding or bleeding problems. So you don't. That's a really important difference with this disorder and how it presents, and obviously then how it's treated. We typically see a different sort of bleeding pattern as well. Classically, it's areas where there's a sort of what we call high fibrinolytic activity, but typically we see, I suppose, bleeding into the mouth or mucosal type bleeding, and it can complicate surgery as well. But it's not something that tends to present with sort of spontaneous bleeding into joints and muscles.
And you've said it's often asymptomatic, most commonly problematic after surgery or or trauma.
Yeah, that's fair to say. And we may see it with manifesting itself with heavy menstrual bleeding or post-operative sort of bleeding.
And there's no recombinant factor 11 or treatment for this condition.
Yeah.
Is that right? So
That's right.
it's plasma-derived factor 11 concentrate that is the mainstay of treatment when it is required.
Yes, and very much when it is required. So it's quite unusual to require factor 11 a factor 11 replacement in this sort of disorder. Most of the time, the bleeding phenotype is mild, and usually we would use adjunctive sort of measures like tranexamic acid. The slight concern with some of the concentrates has been an increased risk in thrombosis. So it's when it's given in a very carefully considered way, and usually at a lowish dose.
And we can see from your report an idea of the kind of figures of those who might receive the factor 11 concentrate, which is produced from, as I say, from human plasma. 45 patients received factor 11 in the UK in 2018-19, which is 1.3% of registered patients with the deficiency. As well as tranexamic acid, which you've described as remarkably effective for factor 11, fresh frozen plasma is also used.
That's right, yeah. Quite often, I think, because of those concerns about thrombosis.
And then von Willebrand disease. Can you tell us what that is, please?
Shall I take this one?
Yeah.
Von Willebrand disease is a disorder of the von Willebrand factor protein, which is so it can either be low levels or low functioning levels of von Willebrand factor. And von Willebrand factor is quite central to coagulation in two parts. It's involved in platelet aggregation and adhesion, which is very important for clotting. And it's important because it stabilises factor VIII in the circulation. It's classified in different ways. So type 1, where you have reduced levels of von Willebrand factor and reduced function with those levels. Type 2, where often as well as the low levels, it doesn't function normally. So there's a mismatch between its activity and the amount of the protein in the blood. And type 3, where you have effectively undetectable levels. Type 2 is further classified. It's type 2A and type 2M, which are where you basically have von Willebrand factor at low levels, but it doesn't work so well. 2N is a particular type where it doesn't bind to factor VIII, so you get low levels of factor VIII. And 2B is to do with this interaction with platelets, and you get it binds overly eagerly to the platelets.
And what you've said is in the report is there can be diagnostic uncertainty in von Willebrand's. You'll have people with a clear tendency to bleed and bruise, but that won't necessarily be reflected in the VWF levels. And then some people may have a tendency to bleed with low levels. Some may have low levels but not a tendency to bleed. Is that right?
So there can be very clear diagnosis of von Willebrand's disease where you have very clearly reduced levels and a bleeding type. And then there is a group where the levels are somewhat lower than what we consider the normal range. And often in those cases it's been called von Willebrand's disease. There's a certain question in some studies whether the problem is that if somebody presents with bleeding problems and nosebleeds, then we do a lot of tests, and if one of those tests comes back abnormal, then it's the belief that that is causing the bleeding problems. Perhaps it's not always the case. And I think in von Willebrand's disease that's sometimes the case, so it's not 100% clear in those cases with lowish levels, but not very low levels, that the low von Willebrand factor is causing the problem. And there's a bit of caution about the diagnosis for that reason.
And typically it is a milder sort of disorder with a very, very variable picture. And we tend to, the pattern of bleeding, again, just as opposed to, say, the haemophilia A and B that we've talked about, it tends to be this sort of mucosal type, the sort of primary hemostasis which is affected, so we get easy bruising, nosebleeds, gum bleeding, that sort of picture, rather than the deep tissue bleeding, except in perhaps the the type 3 where factor VIII levels are low as well.
So it's in that category that you might have what you describe in the report as haemophilia type bleeding.
Yes.
And then, again, is this something that would predominantly run in the family but also occur spontaneously, or is it roughly equal proportions?
I don't know the proportions. I would,
No, I'm not sure either, actually.
I would estimate, if anything, there seem to be more cases with familial links than otherwise.
Much like with haemophilia, there is an acquired form as well, but that's very rare.
Are there any, or what are the diagnostic criteria, given that there may be a slightly more complicated presentation in relation to von Willebrand's? Are there guidelines or standards, criteria, thresholds by which you would diagnose von Willebrand's? Are there risks of misdiagnosis or conditions that need to be excluded?
I suppose the diagnosis is, well, it depends a little bit on why you're suspected in the first place, I suppose. So if you've got a family history, then you can cautiously pursue testing in the early sort of phase of life, but it is worth noting that the levels will not normalise until 6 to 12 months of age. So yes, you can do the same sort of testing that we talked about for, screening for haemophilia A with cord bloods and that sort of thing, but actually you may miss diagnosis in that sort of setting. So we do need to be cautious if you're doing tests in the early phase of life for, if you're screening for a known disorder in the family. So that's really important, just to remember that the levels do fluctuate, like we talked about earlier on. The other time that I suppose you'd be testing for it would be if you had an abnormal child with easy bruising, for example. It's quite often picked up in the setting of screening for non-accidental injury, for example, or maybe later in life if there's post-operative bleeding or heavy menstrual bleeding, those sorts of things. And that's the where bleeding symptoms are felt to be out of keeping with normal, then that would be a time to do further haemostatic investigations.
There is a national guideline from the UKHCDO which we try and follow, which details some of the details of the testing. It is, as you say, more complicated, the different aspects of testing than simply doing a factor VIII level in haemophilia A.
And then inhibitors can occur with type 3 but not type 1 or 2.
Yeah, I don't know that they're reported in type 1 or type 2. Yes, they do occur at times in type 3.
What's the primary treatment and the approach to treatment for von Willebrand's?
So generally, it's reactive rather than preventative, depending on the patterns of bleeding. Even in type 3 von Willebrand's disease, the patterns of bleeding are very variable, and some people don't bleed from year to year. And so it tends to be managing issues as they come up. And those issues may be around recurrent nosebleeds, about bleeding from the mouth. They may be around heavy menstrual bleeding and managing that. There's a number of issues. There may be more trauma-related, so in response to injury, or covering surgery or dental procedures. So it's depending on the situation.
And if treatment is required, is it most likely to be DDAVP or tranexamic acid or something else?
Or depending on the levels. So again, it depends on the baseline levels and the baseline activity of the von Willebrand factor, and it depends on the situation as to whether DDAVP or tranexamic acid or factor concentrate. So factor concentrate would be often talked about plasma-derived factor VIII, also contain von Willebrand factor. They vary slightly in how much von Willebrand factor they contain, but there are products that are particularly designed and marketed as for treatment of von Willebrand factor, and they're used.
So there's no recombinant equivalent for VW?
There is a recombinant von Willebrand factor that's just come to the market now. It is not licensed for prevention or licensed in children, and I don't think it's yet funded in the NHS, but it's recently been developed. And so we don't quite know how that's going to fit in, and where it will be most used.
Just one thing about treatment as well is that in the paediatric cohort, if a child with more severe von Willebrand's disease needs treatment, we don't use DDABP in that sort of setting. So typically after the age of maybe 2 or 3 years, it's felt safe. But before that, because of the changes with fluid retention, there's a risk of particularly of sodium levels dropping and causing fits and seizures. So we don't tend to use it in that sense. So if there is a need for treatment in that group, they tend to have the plasma-derived von Willebrand's factor concentrate, and then after that we would do the DABP tests and use that more often.
And you've drawn attention in your report to the particular problems that women, and I should make clear, women will suffer from von Willebrand's. Is it pretty much equally as much as men, or is it more women than men?
Same.
One would predict equal numbers, but possibly reflecting that there are particular difficulties for women with von Willebrand's disease. There are more women registered in the UK with von Willebrand's disease than men.
And the particular problems they can experience can be related to menstrual bleeding.
So menstrual bleeding can be a big problem in von Willebrand's disease, yeah.
And pregnancy. There can be a severe drop-off in VWF levels after delivery and a risk of postpartum hemorrhage.
Yes.
There's a handful of more general questions I have about bleeding disorders, rather than specific to the 4 that we've looked at. Life expectancy. So I'm not asking you to comment upon life expectancy for those with hepatitis C or HIV. We've had some evidence from others in relation to that. But just generally, in terms of life expectancy nowadays for somebody with any of the forms of haemophilia or von Willebrand's that we've discussed, what's known about that?
So I think typically we would expect life expectancy to be approaching normal now. I suppose that having inhibitors may affect life expectancy, but essentially my feeling is that we're seeing patients with, or people with haemophilia rather, growing to an older age, and that's evidenced by the fact that we're starting to see some of the diseases of older age as well, and that's an area of particular interest to some clinicians now.
Does having a bleeding disorder impact upon a person's susceptibility to infection more generally, as far as you know?
I don't think we've had any clear evidence to that. I mean, there is theoretical considerations that the clotting system and the immune system are not entirely disconnected, but I don't know of any clear evidence to suggest that.
Just if I
Yes,
may add,
absolutely.
Because bleeding, when you say bleeding disorder, we've been talking so far about inherited conditions, but when people have severe bleeding and they're given blood transfusions, there's some suggestion that blood transfusions, especially red blood cell transfusions, can affect a person's immune system, and it's easier to acquire infections. It's relatively new areas in the literature.
Thank you. Can I just explore, in relation to haemophilia, some issues relating specifically to women? What's the difference between someone with haemophilia and a symptomatic carrier? Is there in truth a difference?
Not in my opinion. A symptomatic carrier is often being used. I don't know why we use that terminology particularly, but there are women who have low factor VIII levels, therefore they have haemophilia in my view.
That's been my opinion as well, actually.
Thank you. And then I've just some questions about aspects of modern haemophilia care. Am I right in thinking it's still organised through haemophilia centres?
Yes.
It's a form of specialised care, and you've referred already to some of the standards that are set for haemophilia care through UK HCDO. I wanted to look at a couple of aspects of a set of quality standards. Henry, could we have EXPG 5029, please? So these are described as quality standards, care of people with inherited and acquired haemophilia and other bleeding disorders, July 2018. And I think we've discussed this before you came in, you're broadly familiar with this document. There were two aspects of it that I wanted to ask you about. So if we could go, please, Henry, to page 12.
Is it worth contextualising
Yes,
what these
please
standards
do.
are?
Yes.
That as one of the processes of ensuring good care for people with haemophilia is a process of what we call peer review, whereby each centre, so haemophilia centres are organised into what we call comprehensive care centre, which would be a specialist regional centre, and then haemophilia centres who will manage the day-to-day care of patients who are closer to that town, but usually will be linked in with a comprehensive care centre. And there is a peer review process where clinicians from different centres go and assess the care of people with inherited bleeding disorders in different centres against different criteria, and these are the criteria that are used for them.
Are these standards that every comprehensive care centre is expected to meet in every respect, or are they more aspirational?
Without prejudging the results of the recent round of peer review, I don't imagine any centre reached every standard, and some of them are probably more aspirational than...
I'm going to ask you just about two aspects of them. So if we go to the bottom of page 12, please, Henry. Thanks. So we've got a heading, staffing levels and skill mix. If you look down towards the very bottom of the page, we have E, clinical or counselling specialist psychologist or appropriately trained psychotherapist. So this sets out use the word relatively, an aspiration or a standard that staffing should include amongst the other specialities we set out there, that are set out there, a specialist psychologist or psychotherapist. Two questions arising from that. First of all, do you have any sense as to the extent to which that's achieved in practice in haemophilia centres?
Yeah, I suppose on the use of term aspirational, I'd just slightly roll back. I think it's laying down what we think should happen. That doesn't mean that every centre is able to do that, whether the funding is in place for every centre to do that.
It's useful to have a framework like this set out by the UK HCDO, so that we can then say to our hospital, I can say to my boss, actually, I need this, and then we can try and work towards having the things that we may not currently have to provide this standard. I suppose, yeah, but
So we have a psychologist very much embedded within the multidisciplinary team, treating, looking after families with children with haemophilia, and it's a vital part of the service, we think. I don't think, I'm fairly sure not every centre has the same access to psychologists.
And would you expect the focus of the psychology expertise that might be delivered in those centres which do have a psychologist to be counselling and support in relation to haemophilia and other bleeding disorders? Or would you expect them to be able to provide specialist psychological support in relation to hepatitis or HIV?
In general, speaking for our service, that they will try and support any aspects of care. But sometimes when there's interaction with other services, then it may be that there is more specialist provision within those other services. So we wouldn't necessarily expect that our clinical psychologist would be an expert per se in issues relating to hepatitis or HIV, but will be an expert in dealing with psychological trauma and having expertise in different modalities which may well be applicable, or be able to tie in with signposting where there may be other support. But I think in general, my experience is that support from psychology services is very patchy within the NHS in general.
I would agree. Yeah, I would agree with that. Yeah, and we have access to psychology services, but we don't have a specialist psychologist, and I wouldn't expect them to have a great deal of experience with individual disease conditions, or certainly not a combination necessarily of disease conditions.
And then before we break, sir, just one further question in relation to this document. If we go, please, Henry, to page 16, we can see at the top of the page under the heading Specialist Services, it refers to timely access to the following specialist staff and services should be available as part of an HCC service. HC should be able to access these services through network arrangements, and we see a range of different types of specialist service, including at G, HIV services, and H, hepatology. As I understand this document, please correct me if I'm wrong, what this is envisaging is that where you have a patient under the care of your centre who may have needs that fall within any of these areas, you would expect to be able to, as it were, to make a referral or put them in touch with the relevant specialists. You wouldn't be offering those specialist services yourself.
That's correct, and more than that, we would expect some kind of relationship and communication with those services to facilitate the particular care that our patient group would need. Yeah.
I'm sorry, I interrupted. I beg your pardon. So what this would mean would it that someone who was a haemophiliac who had HIV infection or hepatitis infection or both could get the services of a psychologist who knew about haematology but not necessarily about HIV or hepatitis, or he could be referred to someone who was a psychologist working with the HIV and hepatitis services who knew nothing very much about haematology.
I mean, talking about, so I guess that's going back to the previous issue. I think it's possible that they may have access to a psychologist with expertise in haematology, but not HIV or hepatology. They may have access to a psychologist with expertise in hepatitis and HIV care. They may have access to both, or they may have access to neither. And that's where I mean it's extremely patchy, and I don't think different centres organise services in different ways, and many services don't really have access at all, or only have access to a general provision, which is often after a very long wait.
And this particular standard is not, in fact, concerned with psychology as such, but concerned with those who might need care for their HIV or for their liver. You would not be providing that or providing treatment in relation to that within the modern haemophilia centre, but you may make specialist referrals, and we see later on in this document there's a reference to the possibility of having multidisciplinary clinics.
Yes, yeah.
And that's correct. There would either be an expectation of established pathways for referrals for patients to access those services, or a joint clinic.
But you'd expect in the modern era treatment and care for HIV or hepatitis to be undertaken by specialists in those particular fields.
Yeah.
I would, yeah.
Yeah. And I think that what's worth noting here, I suppose, with specialist services, unlike perhaps psychology services, it would be unthinkable that that a haemophilia centre wouldn't have access to HIV services and hepatology. That would be a absolute expectation.
So is that a convenient point to stop?
Yes, it is. 2:00. We'll take a break. 2:00.